Hi everyone, welcome back. Hopefully you had a great little summer break. We are, of course, doing our OB class asynchronously, very similar to how we had our foundations class last year. So it's really going to require you guys to of the material and really reach out to me if you have any questions about any of this material. This first module is pretty straightforward, especially for those students who have already had a little bit of OB experience. So some of this may be a little bit redundant, but some of this information is going to be new. It is all equally important when we are starting to layer the foundation of how we actually scan OB patients or how we scan these babies. So we are going to be starting with some terminology first. Now, the OB world has a lot of different wording, terminology, a lot of different diagnoses that we haven't really heard of before. And this is not specific to just ultrasound. We're talking about OB as a whole here. So we work really closely with a lot of nurses, with a lot of OB doctors. So if you do end up interested in scanning OB, chances are you are going to be working in an OB office with an OB physician instead of a radiologist. So we're kind of shifting gears from general ultrasound here. So one of the most common terms that we hear is gravidity and parity in hand with each other, and it's really important for us when we're getting our patient history to know what this is for that patient. So gravidity is talking about the number of total pregnancies that that patient has had, and then parity is talking about the number of births. We're typically referencing a birth as greater than 24 weeks gestational age. So this is regardless of the outcome. So even unfortunately, if a patient has had a stillborn at maybe 32 weeks, we're still going to count that as a birth, as an actual birth for that patient. So we do this in a way where we are labeling or annotating the number of pregnancies. So G, the number, P, the number. It gets a little bit confusing when we're talking about patients who have had a lot of miscarriages or have had a lot of twins or multiple pregnancies, and we'll talk about that on our next slide. We do have some examples to walk through the difference between gravidity and parity. Another thing that we are using to kind of reference how far along a patient could be if they haven't had any prenatal care at that point is fundal height. So this is something that a physician or a clinician is going to be performing on their OB patients. They're actually measuring from the pubic symphysis of the mom right to the fundus or the tip of the uterus. And this is typically going to correlate right to that fetal growth, fetal age. Also gestation age or gestational age. This is the length of time from conception to birth. So this is really what we are relying on when we are doing these exams and we are following babies on ultrasound. We don't necessarily care so much about the menstrual age because it's a little bit variable. A lot of moms have irregular cycles. A lot of moms can have a cycle throughout their entire pregnancy. So we're really not relying on the menstrual age as much as we are in the gestational age. The menstrual age is going to be the last normal menstrual period, LNMP, last normal. It's important to put emphasis on that because some moms in those first few months continue to spot. And that's very, very, very common in early pregnancy. That's that endometrial lining starting to shed. So it can be confused as another period when in fact it's just implantation bleeding or some sort of just residual bleeding from the previous period. So from the first day of the last normal menstrual period, which is conception plus 14 days, would give us our calculated menstrual age. So again, very variable. We're not really relying on that too much. Also, embryologic age, this is from the time of fertilization, usually going to be within 1 day of ovulation, right? We just learned about that ovulatory cycle in our GYN class, and we really only know that there's a short period of time that that ovum can be fertilized before it's going to start to degenerate. So it's really going to be a very precise measurement if we can calculate that embryologic age. HCG, this is something that we are going to reference throughout this entire semester. This stands for human chorionic gonadotropin. Now, this is the hormone that's going to be produced when there is a pregnancy. So this is how, when we're doing a urine sample or a blood sample, this hormone is going to pop up on those tests, and it's going to say, whoa, wait a minute, this wouldn't be in this patient's system if they weren't pregnant. So this is actually produced by the pregnancy, specifically by the trophoblastic cells. Now, the trophoblastic cells are very primitive, very early on structures and cells that are going to be responsible for a lot of development of that baby. Also, sometimes you get a lot of abnormalities that come from those trophoblastic cells, which we're going to learn about as well. So we'll definitely be coming back to HCG and trophoblastic cells and tissue later on in the semester. So here we have a little bit further clarification of what parity and means, or gravity. So here are some kind of subterms that we can use for that, or that you may see on a rec or an order when you are scanning an OB patient. So nulliparous, this means that this mom has never given birth before. So she's currently pregnant, but she has never given birth before. She could even have been pregnant 4 other times, right? But those pregnancies didn't end up in a birth. So there was some sort of miscarriage or termination in those previous pregnancies. Primigravida, this means, again, that this is their first pregnancy. If this is your first pregnancy, you are also nulliparous, right? Because you haven't given birth before. We have primiparous, which means that we have given birth once before, regardless of the number of pregnancies, right? Because the parity, we're not talking about the number, we're talking about the birth. Multigravid or multigravida, this means that the patient has been pregnant more than once. Multiparous, this means that they have given birth more than once. And multigestation is talking about one pregnancy that has resulted in a multiple baby situation. So this is a single type of birthing event with gestations in that event, so multiple babies in that event. So here we have some examples. So I want you to take a minute and see if you can calculate what their G and P would be. So a woman presents with a history of 7 pregnancies, 3 living children, including a set of twins, and 2 stillborns. What is her gravity and parity? Same thing, a woman presents with her first pregnancy. What would her annotation be? And a woman presents with a history of 3 pregnancies and 3 live births. What would be her gravity and parity? So I am going to post on the discussion board, where you will post what you believe your answers to these examples would be. So here we have different types of abortions. Now, abortion is a medical term, so it can be very controversial, as we know with the current news. This is something that is a medical term and a medical diagnosis and a medical event. So this is not something that, whenever we hear the term abortion, is elective. There are a lot of different types and categories of abortions, and when we are talking about a medical event, this means that this is the terminology for a miscarriage, and we're further specifying what that miscarriage means, or what happened to cause that miscarriage. All of these miscarriages are going to appear somewhat different on ultrasound, and the patient is going to appear different clinically. So it's really important to categorize them so that we can treat them as best as possible, and that they can be aware for future pregnancies down the road. So we're going to talk about some of these abortions first, because a lot of miscarriages are going to happen in the first trimester, a lot of times even before the mom even knows that she is pregnant. So this is something that we're seeing really, really early on in the OB journey of our patients. So we need to be aware of what these miscarriages or these abortions are before we can start to learn about that normal first trimester development. So the first one is a threatened abortion. This is indicating that the future of this current pregnancy is somewhat jeopardized for a specific reason. So it means that the pregnancy is going to continue, but there's something going on that can result in a probable miscarriage down the road. So 50% of these threatened abortions are going to end up in the miscarriage of that baby. So we actually cannot diagnose this on ultrasound. This is something that is done clinically. So these patients will come in in that first trimester, they are going to have bleeding, they're going to have cramping, kind of like idiopathic bleeding and cramping. We don't really know why they're having that. The bleeding is more than implantation bleeding or spotting. So we know that there's some risk with that, especially with the cramping as well. So we know that this is going to be some sort of threatened pregnancy, and we're just hopeful that it is the 50% that is going to continue on with a normal, healthy pregnancy. But unfortunately, 50% will not. Next is an inevitable abortion. So this is a little bit more worrisome. This is very unfortunate for these patients. This is going to be mainly done clinically as well, but now we can start to see this on ultrasound. We're going to start to see some signs on ultrasound that say, okay, this is not looking good for this baby and for this mom. Those clinical symptoms are going to be the effacement of the cervix, so the thinning of the cervix, which we don't want, the of the cervix, which we also don't want. Now, effacement and dilation go hand in hand with each other right before the mom is about to give birth. Those are those signs that we know that the mom is ready to give birth. Of course, we don't want that to happen early on in the pregnancy because it's not time yet, right? So we rely on that cervix to keep that baby in utero for as long as possible. And if it's thinning and spreading, we don't want that. It's going to result in ruptured membranes. So all of the membranes in the sacs that are keeping the baby in are going to start to rupture. So we're going to have loss of amniotic fluid. We're going to have bleeding that persists for longer than 7 days. They're also going to have persistent cramping. So now on ultrasound, we can start to see these changes. Of course, we can see that thinning and that spreading, so the effacement and dilation of the cervix on ultrasound. We're also going to see the gestational sac starting to get lower near the cervix or in the lower uterine segment. We're also going to see that gestational sac starting to look a little bit more abnormal. So now not only is it moving towards the cervix, getting ready to come out, it's also going to have this little crescent-shaped hyperechoic around the gestational sac. So this spontaneous abortion or this unfortunate miscarriage is going to occur typically when we have 2 or more of those clinical symptoms. That's how we can categorize an inevitable abortion. So this means that this baby is still growing, maybe still has a heartbeat, but we have 2 or more of those clinical signs, and we're starting to see some signs on ultrasound, which is pretty unfortunate and will not likely end up in a continued normal pregnancy. Next, we have an incomplete abortion. So this is kind of a miscarriage is actively happening. So we are starting to see the patient go through this miscarriage clinically and on ultrasound. So they are going to have severe cramping, very, very heavy bleeding as they try to start and pass this miscarriage. On ultrasound, we are going to see a complex collection in the endometrial cavity. So we're really not going to be seeing a normal gestational sac. None of those normal first trimester structures are going to be visualized because it's already starting to evacuate the uterus. So we are going to really follow and monitor that patient to make sure that the miscarriage completes itself, and if it doesn't, that we can get them some further treatment. So this is mainly just saying that this is a partial evacuation of products of conception. So all of those really early on structures, the trophoblastic cell and the trophoblastic tissue, maybe a gestational sac, all of those very early on structures of a pregnancy are going to now start to be evacuated. We are also going to see clinically a very slow fall or plateau of those HCG levels. Now, in early pregnancy, we want to see the HCG levels rapidly incline. They typically double within a certain period of time, and we'll talk about that a little bit further on, but we don't want to see those HCG levels decrease or stop rising in the first trimester. So that's going to be another clinical indication that this miscarriage is currently happening. Next is going to be a missed abortion. So this is when we see an embryo. So we see a baby, a fetal pole, but unfortunately they don't have a fetal heart rate. So there's no cardiac activity. We're going to have retained products of conception for a period of time because the mom may not even know that this has happened. That is going to result in a concern of infection. We also are going to be able to kind of find that this has happened with that HCG level again. So like we said, early on in pregnancy, we want to see HCG rise, and typically your HCG levels are going to correlate with the number of weeks pregnant you are. If we see HCG levels not matching up with how far along the mom should be, have to start to question, okay, what's going on? So now we're probably going to order an ultrasound. We're probably going to visualize that baby that doesn't have a fetal heart rate anymore. The gestational sac could be empty. We could see acoustic shadowing in the endometrial cavity. The baby that we see could be really small for the dates. Our uterus could be really small for the dates that the mom should be. So we're really going to see a lagging pregnancy or a baby without a heartbeat. Clinically, these patients are going to have brown discharge and loss of pregnancy symptoms. So they're feel their belly growing. They're not going to have the nausea or the fatigue that typically goes along with first trimester. This is common in the second trimester. So when we are talking about a pregnancy, everyone references being pregnant for 9 months, but in fact, you are not. You are pregnant for 10 months. Pregnancy is 40 weeks in totality. So a normal gestation is 40 weeks. 40 weeks divided by 4 weeks a month is 10 months pregnant. So when we're talking about trimesters, it doesn't go by 3 months. It typically goes by 3.5 months. So your first trimester is going to bring you to about 13 weeks and a few days, and then so on and so forth for each trimester after that. So in the second trimester, we can sometimes just have babies that just stop growing. So usually your risk of complications or your risk of these miscarriages is high in the first trimester, but we also have some situations like these missed abortions that your baby grew and developed throughout the first trimester. Some reason their heart stopped working, right? And the pregnancy did not continue to grow in that second trimester. We next have a complete abortion. This is when we have all of the products of conception have evacuated the uterus and the endometrial cavity. We're going to see a rapid decline in those HCG levels. We're also going to see on ultrasound the endometrium looking pretty much back to normal, so what we call a clean endometrium. The uterus is going to be empty. We may see some leftover echoes or echogenicity or debris in that endometrial cavity. We could see that the surrounding tissue, the surrounding endometrium, is going to be hypervascular for up to 3 days after the miscarriage has completed. And that's because we still have some trophoblastic tissues and cells left in that area. Clinically, the patient's going to have vaginal bleeding with clots. We're also going to see cramping. We're going to see all of these symptoms really disappear really after that products of conception have evacuated the uterus and the endometrium. So really once you have completed that miscarriage, all of that bleeding, cramping, all of those clots are going to stop because the event is done. Now we also have recurrent abortion. We have 2 or 3 consecutive spontaneous abortions. This is really unfortunate for these patients because they may be thinking that 1 is bad enough to have experienced, but now we have somebody who has a history of 2 or 3. So of course they are now going to be considered high risk for any pregnancy that they have down the road. This is unfortunately very common. All of these are common. Miscarriages are common. So it is all about how we categorize them and classify them and how we treat them and make sure that our patient is getting the highest quality possible while us also being empathetic and compassionate to them. You are going to be confirming these miscarriages on these patients. You are the first person who is with them when they get this news because they can see the screen. They can see that their baby doesn't have a heartbeat. You can see that the baby is not there on the screen. So you are there in those very sensitive moments, and this is where our patient care skills and our empathy skills are so, so important. So here we have some images of what these different types of miscarriages are going to look like on ultrasound. So this is an inevitable abortion where we said that we have 2 or more clinical signs that an abortion is likely on the horizon. So this baby may have developed normally. It looks like it's pretty much in that second trimester because we see all of the fetal head bone structures here. They could still have a really strong heartbeat, but unfortunately our cervix is dilated and starting to thin. And we have all of this amniotic fluid kind of gathering in the lower uterine segment and heading into the vaginal canal. So we really don't want that. And really on early pregnancy is unlikely for us to be able to save that baby. Sometimes we can go in and we can stitch the mom's cervix, but that's not a guarantee that the baby will continue to grow and thrive. Next, we have an incomplete abortion here. So this means that the miscarriage has started and we are able to visualize some of those products of conception in the uterus and the endometrial cavity. So here is our residual tissue sitting in that endometrial cavity. As you can see here, this bottom picture was probably a pregnancy that was much further on than this top image because our uterus is looking pretty large. We have all of this tissue that is still sitting in that uterus and endometrial canal. So this means that the miscarriage is currently happening and we want to monitor and make sure that this patient evacuates all of these structures and all of this material because she can run the risk of an infection. Here is our missed abortion. So our baby just stopped growing. You can see our gestational sac is really pretty large in this bottom picture, and we should expect to see a fetal pole about this big in relationship or in proportion to that gestational sac, but we're getting a fetal pole that's measuring way smaller than we should. So this baby stopped growing several weeks ago. We can't confirm it on this picture, but it's pretty unlikely that that baby still has a fetal heartbeat. Same thing with this image here on the top picture. When we get into our sonographic evaluation of the first trimester, we're going to learn about when you should start to see specific structures. But basically, when your gestational sac reaches a certain size, you're expected to see a fetal pole. You're expected to see a yolk sac in that gestational sac. But here we have a pretty large gestational sac and there's nothing else in it. So again, we know that that baby didn't grow in this pregnancy. Here's a complete abortion. So this means that all the products of conception have evacuated that uterus. It's looking pretty much back to normal. We do still have a tiny bit of fluid in that endometrial cavity there, but that's to be expected. And then we also have some hypervascularity surrounding that endometrium. Right here, this could indicate some residual trophoblastic tissues. So we would just want to make sure that we have that patient come back a few days later, make sure everything's truly looking back to normal. So how do we determine and how do we calculate how far along a patient should be or where they're at? How do we find those discrepancies in HCG? How do we find the discrepancies on the ultrasound between the gestational age, the last normal menstrual period, and the measurements that we're getting on this baby or on this sac? So there's a lot of different ways that we can do that, and it all depends on what type of information you're looking for. So we have qualitative information and we have quantitative information. So qualitative is basically just saying, does this patient have HCG in their system or do they not? So that's basically going to be your urine test. You're at home when you pee on a stick type of test. It's going to tell you, is there HCG or is there not? It's not going to tell you how much HCG there is. That is going to be quantitative information. That's going to be confirmed with a blood test. So a blood test is going to say, yep, there's HCG here. So it's going to give you qualitative information, but it's also going to give you the amount. So we're track that with that quantitative HCG level. We also, if we have a patient who knows their very specific dates, they may know their day of conception, they may know their last normal menstrual period, they may have had truly normal periods for their entire life, we can use an obstetric wheel to help us calculate typically where that patient should be in that pregnancy. We also have Naegele's rule, where this will be asked on your boards, where you can calculate the due date of the patient or the last normal menstrual period, depending on the information that you know. So typically, we're going to know their last normal menstrual period. So you can calculate that by taking 3 months, adding 7 days, and finding what that estimated due date would be. So you take your LNMP, you subtract your 3 months from that, and then you add 7 days. That's going to give you your typical estimated due date. I wish I had statistics on the number of pregnancies or babies that were actually born on their calculated due date because I feel like it's not likely. Here is a picture of a obstetric wheel or a pregnancy. I've seen this out at clinical. It can be a little bit confusing because there's a ton of information on here, and we'll demonstrate this in person. We do have a wheel that you guys can kind of practice, but if you look really closely, my little pencil thing is kind of blocking some of my information. This blue arrow is going to tell you if the patient knew right when their last normal menstrual period was, you place that blue arrow right on that date. So say they told you that their last normal menstrual period was February 15th. You're going to roll that wheel right to February 15th, right? it's going to push this due date back to, I don't know, somewhere in November, right? So everything else, we're not really going to be using too much in ultrasound because we can use the specifics of actually measuring the baby and the image to help us. But you can see here that this is what the typical crown rump length should be, or the length of the fetal pole. And then also what the typical biparietal diameter should be. So the parietal bones in the baby's head, we measure that later on in pregnancy. So we're not really going to be using that too much because we can actually just measure those things. But we really are going to be relying on calculating what that suspected estimated due date would be if they knew their last menstrual period. The other thing that we could do if they were given a due date by their physician, because a lot of people do not know when their last menstrual period was, but their doctor calculates their due date based off of those HCG levels from their quantitative blood test. So what we can do is we can put that wheel, that approximate date of delivery arrow, this black arrow right here, say they were notified by their doctor that their estimated due date is November 15th, we are going to put this wheel here, and then as we do that, that's going to move the last day of menstrual period to over here somewhere. It'll be a lot easier to visualize this in person when you can actually rotate it and see where the arrows end up. So there are some maternal risk factors that we need to be aware of, especially very early on in pregnancy, but really throughout the entire pregnancy as well. So there's something that we call advanced maternal age, which is pretty insulting. This is known as AMA, and it means any mom who's pregnant over the age of 35. So yeah, some places actually even call it a geriatric pregnancy, which makes me just want to scream. It's extremely insulting, but basically any mom who is pregnant over the age of 35 is considered to be high risk. Again, I wish I had statistics on why that is, but it is pretty unfortunate. There's also a lot of terminology that you guys will see in the OB world that can be really insensitive to patients. You know, women go through a lot. They go through a lot to get pregnant. They go through a lot while being pregnant. They go through a lot if they don't want to be pregnant. So when we use a lot of this terminology and a lot of this verbiage, it can be very insulting and insensitive to patients. So we really don't want to make our patient aware that they're considered a geriatric pregnancy, because trust me, she probably has told that by her doctor. So we want to be as kind and as compassionate as possible. Maternal disease is a big factor in pregnancy. We're going to come back to this towards the end of the semester, but there are some really big maternal diseases that are really going to alter the outcome of a pregnancy. Diabetes is a huge one, whether it's type 1 or type 2 diabetes. This is something that we have to monitor very closely. Also, any sort of autoimmune disease, lupus in particular, can wreak havoc on a developing baby. So we need to monitor these moms very closely. Also, if there's any history of chromosomal abnormalities in the parent's family history, right? So we need to know that. Does anyone have Down syndrome in your family? Does anyone have Edwards syndrome in your family? Because there are going to be links between those genetics and the statistics that your baby could have them. If you have any underlying hypertension or hypotension, right? Is your blood pressure too high or too low? That's something that we need to monitor extremely closely. Also, any sort of uterine abnormalities. So is your uterus too big, too small? Do you have fibroids in your uterus? Do you have any sort of uterine anatomic variation, which we're going to talk about in a second? Do you take any medications? That is a huge one. Drugs and pharmaceuticals play a huge factor in the development of a baby. Even if it's life-saving medication for you, it's still going to have an effect on that baby. You need to be in very close communication with your physician and monitored very closely. Now, uterine fibroids, this is something that I can relate to. I had a I forget how they ended up specifying it, but I had a subserosal fibroid that sat right on the top of my fundus. And I had it surgically removed, and then was pregnant with my son about a month after that. As my uterus was growing, as he was developing, my OB was very funny, and she said, how funny would it be if I didn't have my fibroid removed, because it would be so big and it would protrude so far off of my belly that it would look like the baby was wearing a top hat, if you were to just look at my pregnant belly. And I was like, yeah, that's funny and cute for you, but no thank you, I'm going to pass on that. So fibroids play a really large factor in how pregnancies stick and how they develop. If you have a fibroid that is submucosal, that's going to play a really big factor in how that baby develops, because that's going to be pushing directly on that gestational sac. So you have a little bit higher risk if you have a fibroid uterus and a pregnancy at the same time. Also know that hormones make fibroids grow. So you have an insane amount of hormones traveling through you when you're pregnant. That's going to make that fibroid grow rapidly. So the baby and the fibroid are going to be competing for space, and a lot of times the baby does not win in that battle. So we need to be aware of that patient history as well. So uterine variations, this is something that we should remember from our GYN lectures, but we have all of these different types of anatomic variations that women can have. A lot of women don't even know that they have any of this until they're trying to get pregnant, and then Didelphys, this is going to be the complete duplication of the uterine horn and cervix. Bicornuate is the division of our uterine horn. Septate, this is going to be our most common, and we're going to see this a lot with early pregnancy losses. This is when the endometrium is separated at the top, so at the fundus, and that separation can extend all the way down into the cervix. Unicornuate, these patients are infertile, unfortunately, so they need to seek other options. This is when we have a one-sided uterine horn with only one fallopian tube that is working. Arcuate is when our uterine cavity is concave, so protrudes in towards the fundus. Not really too many complications associated with an arcuate uterus. And then aplasia, of course, is an absent uterus. So these women just never developed one, so of course they cannot carry a baby naturally. I do have a friend who had a uterus transplant, which is phenomenal and really makes me proud of modern science. So let's take a look at what all of these actually look like in terms of our diagram. So here's our normal uterus on the top left corner. We have a nice rounded fundus. We have our normal cervix with our endometrial cavity going up it, right? And then it kind of widens to go to each uterine horn. Now, an arcuate, kind of similar in the sense that our endometrial cavity goes up through our cervix, right, to each horn, but then that uterine tissue at the fundus kind of goes whoop and just divots in a little bit. So we can have some fertility complications with that, but usually these women are going to be able to have normal, healthy, developing babies. Now, bicornuate, this means we have two separate uterine horns, right? So we have that division that's occurring, two separate endometrial cavities. This is how, if you have ever heard of this variation and also this variation, is if you've ever heard of a woman who is pregnant with two babies at two separate times. This is when they have this sort of variation. Also, when women continue to have a period, a normal period throughout their entire pregnancy, that is because they have a baby in one uterine horn, and then they have a period in the other uterine horn. So this is where all of those kind of bizarre pregnancy stories come from, because these women have some sort of uterine variation that allows for it. And then the unicornuate, you can see we only have one uterine horn with a fallopian tube. So next we need to learn about what is important when we're getting our patient clinical history. So of course, like we said early on, the gravity or gravidity and parity, the clinical dates if they are aware of them, any sort of clinical symptoms. So are you bleeding? Are you spotting? Are you cramping? How far along are you? If you felt the baby move, do you still feel them move? Are you having any pain at all? Some further things that we need to be asking further on in the pregnancy: are you lightheaded? Are your feet swollen? Those are all going to be indications of high blood pressure or hypertension. That's very severe for babies later on in pregnancy. We also need to know of any other previous pregnancy complications. So did you have any issues with your pregnancies beforehand? If you had previous pregnancies, did you have any placental issues? Did you have any issues with the umbilical cord? Did you have a C-section? Was it an emergency? So these are some of the basic questions that we need to be asking our patient if they're coming in for a first trimester ultrasound. We also need to know, is this your first ultrasound, right? Did you get an ultrasound in your doctor's office when they confirmed your pregnancy? What are you specifically here for? So the further along the pregnancy we go, the different questions we start to ask. But when we're starting off in that very early stage, this is what we need to focus on. And lastly, we do need to mention our ultrasound safety. So if we remember from our physics class, we talked about bioeffects. Now, there aren't a lot of bioeffects. There's really no bioeffects that we know of in ultrasound, but we get very critical and very aware of the potential to have bioeffects when we're talking about OB imaging. So this is why when we are measuring a fetal heart rate, we are never using pulse wave Doppler. Every other artery and vein that I have told you guys how to scan, we are using pulse wave Doppler to document it, right? But when we're doing that, it's using double the amount of power. We don't want to do that. We just want to prove, to measure fetal heart contractions, and we can do that with M mode. Now, if you remember from M mode, the only thing that it's doing is picking up the distance of a moving reflector. So it's picking up that contraction of that heart in the baby, and it's monitoring, it's really displaying that on our screen as movements at that specific distance in our picture. So it's not using any extra power, it's not using any extra intensity, and it's really the gold standard. If you see people posting pictures of their ultrasound pictures and there is a pulse wave Doppler spectral analysis on there, it makes me really sad to see it because somebody doesn't know their ultrasound physics. Somebody who shouldn't be performing that ultrasound is performing that ultrasound. And who knows how many babies they've performed that on. So it's really, really unfortunate and it's really upsetting. And it's really important for us to educate people in the healthcare community because it's not safe for babies at all. Now, pulse wave Doppler, we can use it only if and when it is absolutely necessary. Typically, it is only going to be necessary when we are looking in the second and third trimester. We can use it to evaluate maternal vessels. So if we're questioning pelvic congestion syndrome, where we're questioning a blood clot in the iliac vessels of the mom right next to the uterus, we can do that. Also, if we're questioning any abnormality with the fetal vessels, so if we're questioning intrauterine growth restriction, we can Doppler some of the vessels to see how severe it is. But again, that is if and only when that is clinically indicated and approved by a physician. Also, any abnormalities with the placenta, if we are fearing that the baby has placental insufficiency or the cord only has a 2-vessel cord in it, we'll learn all about this. We will be Dopplering that. But again, it needs to be approved and it needs to be very quickly and very efficiently. So if you are a new OB tech, they are not going to have you Dopplering those vessels. They are going to have somebody Doppler it who is experienced in that and who can do it very quickly so that we keep our pulse wave Doppler off for as long as possible. So a lot of new information on this PowerPoint. We do still have 2 more PowerPoints to get through for this module, so please jot down any questions that you may have and you can reach out to me.